Hello everyone, it's Dr. Locklear here, and we are continuing our focus on the concept of perfusion. So now today in this recording, we're going to be talking about Exemplar 6K in your Pearson text, and we're looking at pulmonary embolism. So we're going to see how these blood clots affect our respiratory patterns and breathing and how significant and severe PE can be. So of course we're going to describe the pathophysiology. How does it occur? What are the causes? What puts someone at risk for a pulmonary embolism? And how as nurses can we prevent this? So as you're listening to each recording, I want you to think about a patient maybe that you've had already in clinical, and just kind of think of, if I were the nurse taking care of a patient, and this is really how you should study these chapters too. But if I were a patient taking care of a patient with heart failure or coronary artery disease or a pre-op patient or someone with a pulmonary embolism, what do I need to know about the patho? What do I need to know about the causes? How do I educate this patient on the risk factors? As a nurse, what are the clinical manifestations I will see? And then how do I react? How do I analyze the diagnostic test and data? When do I call the doctor? When do I call a rapid response? Because some of these conditions like PE is very life-threatening. So let's look at our overview. Pulmonary embolism results from blockage of pulmonary vascular blood flow due to an embolus, an occluding particle. When the occlusion is a clot, it is referred to as a thromboembolism. These form in the venous system and are carried into the pulmonary vasculature. Other embolic materials include fat, usually bone marrow released during a fracture or from liver trauma, amniotic fluid during childbirth, or erroneous IV injection of air or other materials. So you should automatically be thinking, if I have somebody with a fracture, I might get a fat embolism from that broke bone. If I have somebody with a liver injury or an abdominal injury, or a mother who has had a child. So this should put me on alert, that, and anybody that's had surgery as well. Pulmonary embolism can be life-threatening. PE deaths occur within 2 hours of the emboli occurring, requiring emergent medical attention. Unrecognized deep vein thrombosis, or DVT, can also lead to a pulmonary embolism because it can travel and lodge in the lungs. What is the pathophysiology? So you should be thinking, how does this situation occur? What do I need to look for? As venous blood enters the pulmonary vasculature from the right heart, it travels through the pulmonary capillary bed, the mesh-like structure in the alveoli walls where oxygen and carbon dioxide exchange occur. This blood flow, or perfusion, must match with the lung ventilation for effective respiration or gas exchange. Local factors regulate ventilation and perfusion to maintain this match. A low alveolar oxygen level leads to alveolar capillary constriction, shunning the blood to functioning parts of the lungs. When DVT rarely travel to the lungs, proximal thrombi forming in the popliteal and iliofemoral veins can break loose and flow through the enlarging venous system until the pulmonary arterial system is reached, where they lodge. Pulmonary arterial blood flow occlusion by PE varies by the magnitude of the embolism and the location. Sudden death occurs with large PE occlusion due to cessation of gas exchange and blood flow to the heart. So these are very large blood clots in the lungs. Pulmonary infarction can occur when pulmonary blood flow is blocked. However, less than 10% of PE result in pulmonary infarction. The infarcted areas of the lung scars and becomes fibrotic, which can lead to other problems. Lung parenchymal injury occurs when a small segment of the pulmonary circulation is occluded, but usually no permanent lung injury remains. When current emboli occur, occluding pulmonary vasculature symptoms can repeat. Both perfusion and ventilation are impacted by pulmonary vascular occlusion, triggering additional clinical responses. Vasoconstriction is triggered by neurohumoral reflexes, leading to increased pulmonary vascular resistance. As symptoms worsen, pulmonary hypertension and right ventricular heart failure result. So your heart's affected, the pumping action's affected. Hypotension and cardiac output reduction can develop. And so as this hypotension, the blood pressure drops and cardiac output reduces, the body's starving of oxygen. Dead space forms where alveoli are ventilated, but blood does not flow through the capillaries. Atelectasis, which is lung collapse, risk increases as surfactant levels decrease. So causes a lot of problems. And here's some diagrams of what a fat embolism looks like and what a thrombus blood clot looks like and how it occludes. The thrombus arising from the lower extremities is the leading cause of PE. Fat emboli, which occur because of trauma resulting in fracture or liver damage or surgery, are less common. So usually it's from a DVT in the legs and it travels, but that's very common when you have surgery and you're not moving around. What are the risk factors? The risk factors for pulmonary embolism are similar to those for DVT and include stasis of venous blood flow, vessel wall damage, and altered blood coagulation, inherited thrombophilias, and certain cancers that produce coagulation factors make clot formation more likely. Risk factors for DVT include prolonged immobility, not moving around. The blood stays like stagnant in your legs. It's not flowing back and forth good. And we all have blood clots, tiny blood clots. So the less we move around, they get bigger and they can clump together. Anybody who's had trauma, including hip and femur fractures, surgery, any type of orthopedic, pelvic, and gynecologic surgeries in particular, MI and heart failure, obesity, and advanced age. A family history of DVT or PE may also indicate risk for the condition. Females who use oral contraceptives, and this is very important, females who use oral contraceptives or estrogen therapy are at risk, as are women during pregnancy and childbirth. So these particular people, women are really susceptible when they're on these particular medications, estrogen therapy and contraceptives. Women during pregnancy and childbirth are at risk as well. Smoking cigarettes also increases the risk of pulmonary emboli because of vasoconstriction. The incidence of PE is higher in the black patient than in white patients, although coagulation or procoagulation disorders such as factor V, Leiden, and prothrombin gene disorders are more prominent in white patients than in the black populations. So how do we prevent it? So one thing, it is crucial to prevent the clots caused by DVT. We've got to be very proactive. Hospitals commonly take aggressive measures to prevent such clots, including administering anticoagulants before or after an operation for individuals who are at risk for clots, or for those who were admitted with a heart attack, stroke, or cancer complications, using compression stockings to keep the blood from stagnating during surgery, and or the pneumatic compression devices, or your SCDs, to squeeze the leg veins with air compression to improve blood flow. Encouraging physical activity in patients as soon as possible following surgery, and elevating legs during bed rest. Patients may help prevent PE while traveling by taking breaks from sitting, flexing ankles while sitting, and drinking plenty of fluids and wearing support stockings. And while we're in clinical, you really need to wear those support stockings, and they sell them everywhere. You know, don't cross your legs. Get up and move around. Physical activity is very good for blood flow. Clinical manifestations. So nurses, what are we going to see? What do you look for? What are you assessing for? The clinical manifestations of PE depend on the magnitude and location of the emboli. Small emboli may be asymptomatic. Symptoms develop abruptly. Abruptly means like suddenly, over a period of minutes. The cardinal symptom of PE is dyspnea, shortness of breath. The patient will sit straight up in the bed, grab their chest, and say, "I can't breathe." And when you see that, you better be moving. Call rapid response. Okay. The cardinal symptom is shortness of breath. Pleuritic chest pain can also be present, and they'll sit up and grab their chest. Reports of a sense of impending doom, like they are dying, anxiety, and cough. As the occlusion continues, diaphoresis occurs and hemoptysis, so they're maybe having some bleeding. Syncope and cyanosis can indicate extensive PE. Tachycardia and tachypnea are present on examination, as well as a S3, and possibly S4 gallop. That is very important because we shouldn't have a gallop, okay? We should have S1, S2 in our heartbeat. Lub-dub, S1, S2. S3 and S4 heartbeats are abnormal. It's important to know. A cardiac gallop, S3 and S4, may be noted. A low-grade fever, due to diffuse symptoms, differential diagnoses between PE, MI, or pneumonia can be difficult. So they're going to have to do some diagnostic testing very fast. Characteristics manifestations of fat emboli include sudden onset of cardiopulmonary and neurologic symptoms, dyspnea, tachypnea, tachycardia, confusion, delirium, and decreased level of consciousness. Petechiae often develop on the chest and arms, and these are like little ruptured capillaries and blood vessels, and you'll have little red spots. So what's our collaboration? Prevention of pulmonary embolism is dependent on the DVT prevention. Early patient ambulation reduces venous stasis and resulting blood pooling. So remember, teach them while you're sitting down, move your ankles around, flex your legs while you're in the chair, lift them up and down. Early patient ambulation, you got to get them up. It helps reduce venous stasis and resulting blood pooling in the lower extremities. External pneumatic compression of the legs is also effective for patients undergoing surgery or when anticoagulant therapy is contraindicated. Other preventive measures include elevating the legs and active passive leg exercises. On this page, between clinical manifestations and collaboration, I probably could get 10 NCLEX questions. So that means this is important, right? Treatment of pulmonary embolism is supportive. Oxygen therapy is initiated. You don't have to have a doctor's order in an emergency situation if you know the oxygenation is impaired. Go ahead and put it on. You'll be covered by standing orders by the facility. Oxygen therapy is initiated, and you usually do it at about 2 liters. And analgesics may be ordered to relieve the chest pain and the anxiety. These both can promote pulmonary arterial dilation. If the patient care is in a critical care setting, pulmonary artery and wedge pressures may be monitored with a balloon, which is a Swan-Ganz catheter. Cardiac output may also be assessed. Cardiac rhythm is monitored to detect dysrhythmias. And when this happens to these patients, they're going to put them in ICU. Safety alert. When applying external pneumatic compression boots, be sure to apply the correct size. Compression boots that are too small or too large will be ineffective at preventing DVT and PE. Ensure that boots of all sizes, including extra large bootses, are on hand. And I said bootses. That's funny. Extra large boots. You get caught up when you're recording this stuff sometimes, and it don't always come out right. So that's the one you can laugh about, Dr. Locklear. All right, diagnostic testing. Before performing clinical tests, patients with suspected PE should undergo criteria testing with the pulmonary embolism rule-out criteria, or PERC, modified Wells criteria, or the Geneva criteria. Patients who have a low probability of having a PE on the basis of these criteria will probably not need to undergo further testing, but they should continue to be monitored because a small percentage of patients with a low score eventually have a PE. And here's the following criteria. A pulse rate greater than 99, pulse ox less than 95 on room air, history of DVT or PE, hemoptysis, recent surgery or trauma requiring hospitalization, cancer treatment, unilateral leg swelling. Okay? And then here's some further testing. If the criteria tested indicates that the patient's at risk for PE, then the patient should undergo further testing such as an ultrasound. And so here's some tests that you would have. You have the chest CT with contrast, and this shows the large central pulmonary emboli very clearly. Chest X-ray can show pulmonary infiltration and pleural effusion. CT angiography is definitive for PE when other less invasive tests are conclusive. So the CT with contrast is the principal test. Lung scans, the VQ scan, ventilation versus perfusion. You're looking at ventilation and perfusion with the VQ scan. Another one is the D-dimer, and you will need to know D-dimers out in practice, not just for testing purposes. They're indicative of the presence of a thrombus because the D-dimer is a fragment of fibrin that is formed during the lysis of a blood clot. Elevated blood levels of D-dimer indicate thrombus formation and lysis. Safety alert. Isotopes used in lung scans may cause allergic reactions in some individuals. Before a lung scan is performed, the nurse should ask the patient about any previous allergic reactions. In addition, because of the potential harm to the fetus due to radiation, female patients should be asked if they are pregnant or they're planning to become pregnant. Breastfeeding mothers should be cautioned to refrain from breastfeeding for 24 to 48 hours after getting this. Electrocardiography is to rule out the MI, and they're looking for association with PE, including nonspecific T-wave change. ABG measurements usually show hypoxemia, so you have a PaO2, which is oxygen, less than 80, and may indicate respiratory alkalosis, pH greater than 7.45, PaCO2 less than 35. And so when you're in respiratory, your CO2 goes in one direction and your pH goes in a different direction. And we'll talk more about that, but I do want you to start getting some understanding of how to read pH. So if it's respiratory, the pH goes one way and the CO2 goes another way, and that determines whether it's acidosis or alkalosis. Now, if your CO2 and your pH are going in the same direction, then that's usually a metabolic problem, okay? And we'll learn some more about that, but we'll keep talking about that too, because that's very important with a PE. Anytime you have oxygenation issues, you always need to know what the ABG is. And then the coagulation studies, you got the APTT is used to examine the intrinsic clotting pathway and assess the response to heparin. Desired levels with anticoagulant therapy are 1.5 to 2 times the control value. The risk of recurrent thromboembolism is higher at lower levels, and the risk of bleeding increases at higher levels. The international ratio, or INR, is used to assess the extrinsic clotting system and oral anticoagulants such as Coumadin. And the goal for anticoagulant therapy for these is 2 to 3. So if you're on heparin, the goal should be 1.5 to 2 times greater than the control value. And then if you're on warfarin, something oral is 2 to 3. You need to know that. And you need to know that APTT is used for heparin and PT-INR is used for Coumadin or oral anticoagulants. You need to know the difference, okay? Because you don't do PT-INR for heparin, you do APTT. Pharmacologic therapy. Standard pharmacologic treatment for PE is anticoagulant therapy for high-risk patients such as those with DVT. Heparin therapy is initiated with an IV bolus of 5,000 to 10,000 units, followed by continuous infusion at the rate of 1,000 to 1,500 units per hour in the patient with non-PE, and it's regulated according to the APTT reading. The APTT or PTT is monitored frequently until stabilized. Usual duration of heparin therapy is about 5 days, and during that time you have to monitor for bleeding, bruising, bleeding from the gums, bleeding from the nose, bleeding from the vaginal area, bleeding from the rectum, and bleeding in the urine. You need to report all of that to the physician and hold the heparin and report it. Don't let the heparin continue. Now, don't just stop it and not do nothing. If you're going to hold your heparin, because we don't want to put the patient at risk for clots, but if they've got active bleeding, you need to call the physician as well immediately. Concurrent with heparin initiation, oral anticoagulant therapy with warfarin sodium or Coumadin or Jantoven is also started. Warfarin sodium alters the synthesis of vitamin K, thereby vitamin K being the antidote to Coumadin. So if your bleeding times are too high and your patient's bleeding out, they're going to give a dose of vitamin K. If you're bleeding out from heparin, they're going to give you protamine sulfate, and you need to know that, okay? Oral anticoagulant therapy is continued for 2 to 3 months until few risk factors for thromboemboli exist. Longer therapy is used when chronic disorders that increase the risk of thromboemboli are present. Bleeding is a risk associated with anticoagulant therapy. Although major hemorrhage is uncommon, it occurs in approximately 5% of patients receiving IV heparin. Cardiac, hepatic, and renal disease all increase the risk of significant bleeding, as does age over 60. The use of fractionated and low molecular weight heparin is associated with fewer adverse effects and may be considered. Current research suggests that factor Xa inhibitors are also effective and result in fewer side effects and drug interactions. Vitamin K is given to treat bleeding associated with warfarin therapy. It is the antidote. Fibrolytic therapy may be used to treat a massive pulmonary embolus and hypertension. Tissue plasminogen activators such as alteplase, activase, or retivase, or technoplase or TNcase are used to lyse or disintegrate the embolus. And this is called TPA, tissue plasminogen activators. They restore pulmonary blood flow when they kind of disintegrate the clot and reduce pulmonary artery and right heart pressures. Fibrinolysis significantly increases the risk of bleeding, particularly cerebral bleeding. Because remember, when you're bleeding everywhere, and you can have bleeding in the brain that can lead to a hemorrhagic stroke. Contraindications to fibrinolysis include intracranial disease. Now, these are contraindications, so people who are already on fibrinolytic type drugs, and then increased intracranial pressure, they've had a recent stroke or active bleeding or a bleeding disorder, pregnancy, severe hypertension, recent surgery or trauma. All these are contraindicated for some of these drugs. Because of the increased risk of hemorrhage, invasive procedures are avoided after fibrinolysis. So once you've had, once these fibrinolytics are given, the TPAs, if you're not going to have anything else done, because if you continue to do it, you're going to bleed out. But remember, there are people that have contraindications to it as well. Surgery, so let's look at surgery. Surgical interventions can include percutaneous or open embolectomy to remove the clot. Venous screens, filters are used as prophylaxis. So a filter would be like a stent. These interventions are used when anticoagulant therapy fails to prevent recurrent emboli or is contraindicated. Safety alert. If a patient has a vena cava filter inserted and still has many emboli in the legs, the filter may become clogged, causing severe edema in the lower extremities. Monitor the patient for edema and implement preventive measures and prevent edema as well. And then talks about pulmonary embolism in children and in pregnant women, and we've already mentioned some of that. Please read over that. I'd like for you to read over that on your own. Okay. Nursing process. Nursing care is essential to preventing PE, assessing, noticing the signs really early. Nursing interventions include encouraging patient ambulation post-operatively or following acute illness, encouraging use of the compression stockings, teaching leg exercises, and discouraging use of pillows under the knees. As you see, teaching patients is very important in clinical practice, and over the last 2 clinical days that we've had, a lot of you have been doing a lot of teaching as well, and teaching is very important. Patient education should include risk of immobility and steps to ameliorate complications such as walking or doing leg exercises every 1 to 2 hours during long auto trips or flights. Avoid sitting for long periods and avoid crossing the legs. The nurse should encourage regular exercise like walking, at just about 20 to 30 minutes a day. Other instructions include avoiding constricting hose or socks that will promote blood pooling. The nurse can also assist patients with smoking cessation and identifying alternatives to oral contraceptives and hormone replacement therapy. So what is our assessment? Focused assessment is indicated due to emergent nature of PE. The nurse should obtain the following data when assessing the patient with or at risk for PE. Observation and patient interview. So what are we looking at and what are we asking? Most patients with a PE have no observable signs at onset. However, some patients may show signs of chest pain or shortness of breath. Note these signs and interview the patient related to the potential presence of PE. In particular, assess for chest pain, shortness of breath, and other symptoms, including onset, severity, and precipitating factors, history of recent surgery, venous thrombosis, or other risk factors such as childbirth or malignancy, and current medications. The patient interview may include using one or more of the criteria tools such as the PERC or Wells criteria, and assess the patient's relative risk of PE. And you may not have time to do a detailed you may walk in the room and the patient's short of breath and you got to move. You shouldn't stand there and just ask them a lot of questions. Call rapid response, get some oxygen on them, elevate the head of the bed, and you can, once you get some oxygen and stuff on them and call rapid response, you can start gathering some of this data. Think about somebody coming into the emergency room with a pulmonary embolism. They don't have time. They're asking them questions while they're doing interventions, okay? You don't just stand there and ask questions. You gotta move. You gotta put oxygen on, elevate the head of the bed, but all the while you're asking them questions. How are you feeling? Are you having chest pain? When did this occur? And they may be too short of breath to even answer your questions. Physical exam. Assess the patient for level of consciousness, presence, rate, and quality of respirations. The pulse, and they'll probably be tachycardic. Their skin color, which will be changed because they're not perfusing. Temperature and moisture, vital signs, including apical pulse and temperature. Breath sounds and heart sounds. Oxygen saturation level. Neck vein distension and peripheral edema. And here are your nursing diagnoses. Ineffective gas exchange or compromised gas exchange. Ineffective breathing pattern, but in this case it is going to be gas exchange because it is occluded. Here are your goals. O2 sat greater than 94%. Of course, you want to address the anxiety and try to keep the patient calm, because the calmer the patient, it's going to help ease their breathing. Compensate for impaired gas exchange, high Fowler's or Fowler position with the lower extremities dependent, hanging over the side of the bed. This position facilitates maximal lung expansion. Maintain the patient on bed rest. Bed rest reduces metabolic demands. Now, this is during the acute crisis, okay? Assess respiratory status frequently. Stay with your patient. Look at rate, depth, effort, lung sounds, your O2 sats. They need to be on a continuous O2 monitor. Monitor their ABGs and notify the physician of the results immediately. Preserve cardiac output. With the loss of blood through the pulmonary vasculature, with PE, hemodynamic status is impacted. Pressures in the pulmonary vascular system and right side of the heart increase. Blood returns to the left side of the heart, and cardiac output may significantly decrease. A central line for hemodynamic monitoring may be indicated. You need to focus on preserving adequate blood pressure, which is going to help perfusion and get the blood to the vital organs. Instruct the patient to report chest pain. Assess the patient's skin color and temperature. Auscultate their heart sounds. This says every 2 to 4 hours, but it may be you can't leave. Listen for that cardiac gallop, S3 and S4 we were talking about. Monitor their cardiac rhythm. A drop in cardiac output and other hemodynamic alterations resulting from a PE can precipitate dysrhythmias, which in turn can further impair the cardiac output. Administer the vasopressors and other medications that can keep the blood pressure up. And as the blood pressure's up, we know the cardiac output is going to be up as well. And so perfusion is going to be more effective. You want to look for signs of right-sided heart failure and maintain IV and arterial access, so, for medicines and fluids and things like that. Promote safety. The risk for bleeding and hemorrhage can increase as you're giving, as you're giving anticoagulant therapy and fibrinolytics. These impair Norman clotting mechanisms, which increase the risk for bleeding. Fibrinolytics create special risk in the first 24 to 48 hours. So you want to look at the patient's medication regimen. Is there anything that they're taking that can be an inhibitor for these fibrinolytics and anticoagulants? Maintain adequate fluid intake. Administer stall softeners. We don't want them to strain because they could have bleeding from their hemorrhoids. Assess the patient frequently for overt and covert signs of bleeding. Bleeding gums, hematuria, that's blood in the urine, obvious or occult blood in the stool or vomitus, incisional bleeding or bruising of injection sites, joint pain and immobility, abdominal or flank pain because they could be bleeding on the inside. Careful monitoring is necessary to identify early signs. Report coagulation studies. Look at your whatever blood work that they order for the coagulation studies. Keep protamine sulfate available for antidote to heparin and vitamin K as an antidote to curcumin and warfarin. Avoid invasive procedures. You shouldn't be getting a rectal temperature. They shouldn't be going down for invasive procedures during this time. Maintain firm pressure on injection and venipuncture sites. Maintain pressure for 30 minutes following an arterial puncture, because if you don't, it will bleed and bleed 30 minutes or more. You may have to put a compression device on it. Of course, we want to help relieve their anxiety and try to keep them calm, talk to them, short, simple sentences, try to distract them with conversation. You have a calm demeanor, don't get really hyper, stay calm with the patient. And then, of course, our evaluation, we want to have them return to normal, and effective airway clearance, effective tissue perfusion. The nurse should provide continuous assessment and evaluation of the patient with a PE. Even if the patient is currently stable, the status can change at any moment, especially if additional thrombosis dislodge and travel to the lungs. The nurse should have assessment tools and treatments readily available to care for the patient at risk for PE. So again, a patient with PE, sit them up in the bed, high Fowler's, oxygen, call rapid response, try to keep them calm. Somebody call a physician as soon as possible. You stay in the room, yell for help, don't leave your patient, and rapid response will get there, get the patient stabilized, and possibly get them to ICU.